Hello, welcome to Learn from the Case. How are you? Today we have to talk a little about sarcoidosis, from the Greek sarcoides, similar to meat. 37-year-old woman from La Libertad, from Lima. Her illness begins approximately 45 days before admission, with intermittent pain in her knees that did not relieve with rest and that progressively increased until ambulation was difficult. 30 days before admission, feeling of weakness when raising arms and legs was added. Pain in the hands when holding or picking up objects, and a sensation of unquantified temperature rise in the evening, which subsided with the ingestion of paracetamol. So she went to a healthcare center when she was told that she had osteoarthritis and was prescribed intramuscular ketorolac, applied once a day regularly for 2 weeks, with partial improvement of her symptoms. Given the persistence of symptoms, 15 days before admission, she went to another health facility where serology of Rosella was performed, which was negative. Due to the lack of diagnostic precision, she came to our hospital. She had no important background. Physical examination found blood pressure 100 over 60 millimeters of mercury, heart rate 72 per minute, respiratory rate 16 per minute, temperature 37.6 degrees Celsius, weight 100, size 162 centimeters, and a BMI 38.1. In fair general condition, obese, in a good state of hydration, in a semi-sitting position, and with algae facies. Mild paleness of the skin, presence of violaceous erythematous nodules on the lower limbs, measuring 2 by 3 centimeters, painful on palpation, not pruritic, and erythematous papules on the dorsal region of the fingers and hands, measuring 1 by 1 centimeters, not painful, and not pruritic. No lymphadenomegaly was found. In addition, limitation of the range of joint movement of the left shoulder was found due to pain, synovitis in the right wrist, and a positive key sign of the left knee. Pulmonary, cardiovascular, abdominal, and neurological examinations were normal. Laboratory tests only showed elevated erythrocyte sedimentation rate. Chest X-ray showed the presence of parahilar nodules in both lung fields. A diagnosis was established with a pathological study. In the lymph node tissue obtained, the replacement of normal lymph node tissue in more than 95% of its station by multiple no-cascading acid-fast bacilli negative granulomas was evident, thereby ruling out tuberculosis in a back-to-back arrangement and with the presence of multinucleated gigant cells and asteroid bodies, stellate cells inside the gigant cells. Findings compatible with nodal sarcoidosis. And it says that sarcoidosis is a rare disease in Peru. However, there could be undiagnosed cases, especially in places where performing a biopsy is a complex process. There is no data on the incidence of sarcoidosis in Peru. And here they say that the most accepted theory is that the disease develops in people exposed to certain environmental agents that trigger an exaggerated inflammatory response, which leads to the formation of granulomas. Association has been described with environmental agents such as tree pollen, wood burning, anorganic particles, insecticides, beryllium, and aluminium. It has also been associated with infectious agents such as viruses, mycobacteria, Borrelia burgdorferi, and Propionibacterium acnes. Interesting, and the theories described here at the end are very interesting too. Sarcoidosis is a multisystemic disease of unknown etiology characterized by the accumulation of T lymphocytes, activating macrophages, and non-caseating granulomas in affected organs. Caseifying, literally turning into cheese, refers to a form of necrosis that at first glance appears cheesy, caseous, and eosinophilic granular necrosis and cellular debris, and is usually, but not only, a characteristic of tuberculosis granulomas. In sarcoidosis, the granulomas are non-caseating. They do not look like cheese. To give the diagnosis of sarcoidosis to a patient, other granulomatous diseases must have been excluded, especially tuberculosis, and sarcoid reaction associated with cancer. Prevalence ranges between 10 and 40 cases per 100,000 inhabitants in the US and Europe. Most patients are young adults with a slight female predominance, but it can occur in childhood and old age. Blacks and Asian Indians suffer from more severe clinical forms, while asymptomatic disease is more common in Caucasians. In Sweden, men account for 56% of sarcoid cases and become ill at a younger age than women, usually between 30 and 50 years old, and women between 50 and 60 years old. Approximately 30% of patients of Scandinavian origin become seriously ill with the image of Lofgren syndrome, which we will see what it is later. But Lofgren syndrome is usually, although not always, associated with a good prognosis, while patients without Lofgren syndrome run the risk of having a longer course of the disease. Patients with non-Lofgren syndrome typically have a more insidious onset of symptoms. An abnormal immune response of a genetically susceptible host to one of several possible environmental exposures is seen in patients with sarcoidosis. The greatest associations between genotype and phenotype in sarcoidosis are found in the HLA class II region of chromosome 6. Likewise, the identification of temporal spatial cluster of the diseases suggests the possibility of exposure or transmission of some environmental agent. Some studies have shown molecular evidence for the presence of Mycobacterium spp in sarcoid tissue samples, although its role in the development of the disease has not been established. Recurrence of the disease has been described in organs transplanted to patients with sarcoidosis, as well as the development of sarcoidosis in recipients of donors with the disease. Pathogeny. Sarcoidosis occurs because one or more persistently acting antigens induce an exaggerated immune response in genetically predisposed individuals. The antigen is presented to the T cells receptor 2 HLA class II. The antigenic stimulus activates macrophages and determines the release of various lymphokines that cause hyperactivity of cellular immunity. This leads to an accumulation in affected organs of CD4 positive lymphocytes and activate macrophages that secrete interleukin 2, interferon gamma, and other interleukins. which constitutes a T helper 1 type immune response. Serum amyloid A protein, which is involved in the production of various cytokines and the regulation of T helper 1 immune response, appears to be elevated in patients with sarcoidosis. As a consequence, there is a decrease of cellular immunity in peripheral blood and cutaneous energy. Concomitantly, hyperactivity of humoral immunity occurs due to activation of P lymphocytes that can cause hypergammaglobulinemia. In the affected tissues, CD4 positive lymphocytes and activating macrophages transform into epithelioid and multinucleated gigant cells, giving rise to the formation of granulomas. There might be central fibrinoid necrosis without caseosis. The degree of granulomatous infiltration of each organ determines its functional damage and clinical repercussions. The granulomatous lesion can resolve spontaneously or with treatment, or evolve into fibrosis with permanent tissue damage. Tumoral necrosis factor plays an important role in the inhibition of cells apoptosis, with maintenance of the granulomatous process and progression toward fibrosis. Sarcoidosis can have an acute or insidious onset. Acute or subacute sarcoidosis occurs within weeks or a few months. Lofgren's syndrome is a common clinical form. It predominates in spring months, characterized by nodular rosacea of the lower legs, usually women, and or periarticular inflammation, tendovaginitis, mainly men, with arthralgias, often fever or low-grade fever, and sometimes anterior uveitis. On chest X-ray, bilateral hilar lymphomas, sometimes pulmonary nodular infiltrates, are noted at the same time. In general, acute sarcoidosis is associated with good prognosis. In contrast, chronic sarcoidosis has an insidious onset, lasting months, and follows a topid course. The most common symptoms are respiratory, although symptoms from other affected organs may predominate. Exclusive extrapulmonary involvement, stage 0, is more characteristic of chronic forms and makes diagnosis difficult. Pulmonary sarcoidosis occurs in 90% of patients. The most characteristic presentation is bilateral hilar lymphadenopathy on chest X-ray. In the lung, the inflammatory process is mainly located in the alveoli, bronchioles, and small blood vessels. It can be asymptomatic or present with dry cough, dyspnea on exertion, and with normal auscultation. Bronchial hyperactivity may be associated. In general, pulmonary infiltrates are of the reticulonodular type and predominate in the middle and upper lobes. About half of patients develop permanent radiological alterations, and a small percentage progresses to progressive pulmonary fibrosis. Pulmonary arterial hypertension rarely appears as a consequence of advanced pulmonary fibrosis or direct vascular involvement. On the skin, their erosive sarcoidosis, granulomatous skin lesions are present in 15 to 25% of patients with sarcoidosis. In fact, the statistics here give very varied data. The most common lesions are papules, infiltration of all scars, subcutaneous nodules, plaques, and lupus perniosus. Papules on the knees are very characteristic. Lupus pernio consists in infiltrative violaceous lesions on the nose, cheeks, and ears, and, like plaques, are associated with chronic sarcoidosis. Eyes. Eye disease occurs in 15 to 20% of patients. It can be asymptomatic, so it is recommended to routinely perform a slit lamp examination, fundus examination using ophthalmoscope, and, if appropriate, fluorescein angiography. The most common lesions are anterior and posterior uveitis, chorioretinitis, periphlebitis, papilledema, and retinal hemorrhages. Scleritis, conjunctivitis, lacrimal glands disease, dry eye syndrome, cataracts, and glaucoma may also be observed. In the lymphatic system and bone marrow, there might be peripheral lymphadenopathy in the cervical, supraclavicular, submandibular, epitrochlear, axillary, and inguinal regions. Mediastinal, retroperitoneal, and mesenteric lymphadenopathy are also affected. There might be palpable splenomegaly, pancytopenia, and low-density splenic nodules on CD. In the liver, there might be hepatomegaly and mycholestasis. Liver biopsy frequently shows granulomas, predominantly periportal. Severe cholestatic syndromes and portal hypertension may be found. Sometimes low-density nodules that simulate metastases or abscesses can be observed on abdominal tomography. Neurosarcoidosis. Here I am going to talk very briefly about neurosarcoidosis. I have to make a specific video about this. We will see in the future. Between 5 to 50% of patients have a neurological condition. It usually occurs in the initial phase of the disease and as its first manifestation. It has a predilection for the meninges at the base of the skull and produces cranial multineuritis. It most frequently causes peripheral facial paralysis, sometimes bilateral, and involvement of the optic nerve. Other manifestations are aseptic meningitis, seizures, pyramidal signs, intracranial hypertension, hypothalamic pituitary disease with diabetes insipidus or hypopituitarism, cognitive and psychiatric alterations, and spinal cord involvement, elevated proteins, lymphocytic pleocytosis, decreased glucose, and the presence of oligoclonal bands can be observed in the cerebrospinal fluid. Magnetic resonance imaging can show periventricular hyperintense lesion in the white matter, sometimes indistinguishable from those produced by multiple sclerosis. Meningeal galludinian uptake, space-occupying hyperatic lesions, or hydrocephalus. In the musculoskeletal system, polyarthralgias are common, predominantly in the ankles, with or without erythema nodosum. Arthritis are rare. Bone disease is rare and consists of osteolytic lesions that predominate in the hand and feet, although they have been described in multiple bones. Cardiac sarcoidosis. Clinically evident cardiac condition may occur in up to 5% of cases. It produces arrhythmias, such as atrioventricular or bundle branch blocks, supraventricular or ventricular arrhythmias, sudden death, and cardiomyopathy. There might be cardiopulmonary secondary to pulmonary fibrosis. For its diagnosis, 24 hours Holter monitoring, echocardiography, cardiac resonance, and PET are used. Endomyocardial biopsy has a low profitability. Other manifestations, granulomatous infiltrations can produce hypertrophy of the parotid glands and xerostomia. Sarcoidosis leads to hypercalcemia, hypercalciuria, and then kidney stones, and rarely nephrocalcinosis occur. Hypercalcemia is due to an increase in intestinal calcium absorption caused by the production of 1.25 OH2D3, which is vitamin D, by granulomas. Granulomatous and lymphocytic interstitial nephritis and renal failure have also been described. Granulomatous infiltration of the upper respiratory tract is most often located in the nasopharyngeal mucosa and sinuses and can cause nasal obstruction and septal perforation. Severe asthenia is common and impacts quality of life. Gastrointestinal, genital, and endocrine gland involvement is rare. And with this last part, I say goodbye for now. In the next video, we see the diagnosis and treatment of sarcoidosis. As always, you're welcome to leave me your comments or questions. Thank you for the attention and be very, very well.